its thickest point at the center. The bar is gently curved and should not form a sharp angle at its junction with the denture base. Half-round single palatal bar must be bulky to obtain rigidity required for cross-arch distribution of stress. Its bulk may make it objectionable to patient's tongue and causes discomfort to the patient. Let's look at the indications of a single palatal bar. The word of indication describes cases that a dental or medical procedure can be used. The palatal bar should be limited to short span class 3 applications. For example, replacing 1 or 2 teeth on each side of the arch and placed no further anteriorly than the second premolar position. Otherwise, its bulk may produce noticeable discomfort and alteration of speech. Perhaps the only indication for its use is as an interim partial denture until a more definitive therapy. Interim prosthesis refers to prosthesis to be used temporarily and for a short time. For example, these are the prostheses used during the integration of implants with bone until permanent prostheses are made. The word of contraindication describes cases that a dental or a medical procedure cannot be used. So, in distal extension cases, or when anterior teeth are to be replaced, a single palatal bar major connector should not be used. For many years, the single palatal bar was one of the most widely used maxillary major connector. It exhibits limited coverage and it can be well tolerated by some patients, but today it is used primarily in interim applications. The palatal bar has few advantages and should be avoided. Although it is thought to be comfortable due to the lack of mass, generally patients find the palatal bar uncomfortable due to its bulk. Due to its narrow anterior posterior width, it derives little vertical support from the bony palate and must be therefore supported positively by rests on the remaining natural teeth. The palatal bar should not be placed anterior to the second premolar position. Another maxillary major connector is single palatal strap. The palatal strap is the most versatile maxillary major connector. The palatal strap consists of a wide band of metal with a thin cross-sectional dimension. The anterior-posterior dimension of a palatal strap major connector should not be less than 8 millimeters to avoid compromise of its rigidity. The width of a palatal strap major connector should be increased as the edentulous space increases in length. This increase in width not only ensures rigidity but also permits greater support from the hard palate. These are indications of the palatal strap, single palatal strap major connector, better suited for the restoration of short span tooth supported bilateral edentulous areas. For example, Kennedy class 3 used only when 2 or 1 teeth are being replaced on either side. May be used for unilateral distal extension partial dentures, Kennedy class 2 cases. Bilateral distal extension cases, Kennedy class 1, anterior replacement with distal extension bases in the presence of palatal torus, we cannot use this type of major connector. It is an anatomic replica form. Anterior border follows the valleys between ruga as nearly as possible at right angle to median suture line. Posterior border should always cross the palatal midline at 90 degrees. Strap should not be less than 8 millimeters wide or approximately as wide as the combined width of a maxillary, premolar, and first molar. It's confined within an area bounded by the four principal rests. So look at the advantages of this connector. Because the palatal strap is located in 2 or more planes, it offers great resistance to bending and twisting forces. It distributes applied stresses over a broad area. Retention of the partial denture is enhanced by the intimate contact between the metal and soft tissue. Because the palatal strap is inherently strong, it can be kept relatively thin, since this configuration offers little interference with normal tongue action. Palatal strap major connectors are well accepted by patients. In some instances, the patient may complain of excessive palatal coverage. Frequently, this complaint can be traced to improper positioning of the strap borders. Therefore, anterior border of the major connector should be positioned posterior to the palatal ruga if possible. If this is not possible, the anterior border should be terminated on the posterior slopes of prominent ruga. Another possible disadvantage is an adverse soft tissue reaction in the form of papillary hyperplasia. This condition is seen when the partial denture is worn 24 hours a day and normally is accompanied by poor oral hygiene, and it could interfere with speech. Another of the maxillary major connector is anterior-posterior palatal bar. The anterior-posterior palatal bar displays characteristics of palatal bar and palatal strap major connectors. The anterior bar is relatively flat. Its cross-sectional shape is similar to that of palatal strap. Borders of the anterior bar are positioned on the appropriate slopes of prominent ruga, thereby allowing it to blend with the contours of the anterior palate. The posterior bar, this bar, is a half oval, similar to the palatal bar major connector. The two bars joined by a flat longitudinal elements on each side of the palate. This configuration gives the effect of a circle and is considerably more rigid than any of the individual elements. These are the indications of anterior-posterior palatal bar. When supported is not a major consideration, and when the anterior and posterior abutments are widely separated, if there are long edentulous spans that are tooth-bound in class 3. The anterior-posterior bar may be used for the patient who strongly objects to the greater bulk or area coverage of the full palatal plate major connector, when anterior teeth must be placed by the partial denture, and in the presence of inoperable palatal torus, anteropalatal bar can be used. In reduced periodontal support of the remaining teeth that necessitates additional support from the palate, we should not use anterior-posterior palatal bar. Let's look at the advantages and disadvantages of the anterior-posterior bar. The main advantage is its rigidity. The anterior-posterior palatal bar minimizes soft tissue coverage, yet provides exceptional resistance to deformation. But it is frequently uncomfortable to the patient. It derives very little support from the palate, and it, especially the anterior bar, may interfere with speech. Another type of maxillary major connector is U-shaped palatal connector or horseshoe connector. The horseshoe connector consists of a thin band of metal running along the lingual surfaces of the remaining teeth and extending onto the palatal tissues for 6 to 8 millimeters. The U-shaped palatal major connector is the least favorable design of all palatal major connectors because it lacks the rigidity of other types of connectors. The medial borders of this connector should be placed at the junction of the horizontal and vertical slopes of the palate. Rigidity can be increased by extending the borders slightly onto the horizontal surfaces of the hard palate. Another border of this type of connector, anterior border of this type of connector, must be kept at least 6 millimeters away from adjacent teeth. If for any reason the anterior border must contact the remaining teeth, the connector must be supported by rests placed in properly prepared rest seats. Now let's look at the indications of U-shaped palatal connector. Its main indications are in the presence of a large palatal torus or prominent median stur. When several anterior teeth are absent and to be replaced, in case of patients with exaggerated gag reflex, and when periodontally weakened, anterior teeth need some stabilizing support. In the presence of a prominent median suture line or in an impermeable torus, this major connector may offer advantages. The horseshoe connector may be designed to avoid bony prominences without sacrificing vertical support. Its lack of rigidity can allow lateral flexure or deform under occlusal forces, which may induce torque or direct lateral force to abutment teeth. These forces may damage to the associated abutments. Its bulk to enhance rigidity results in increased thickness in areas that pardon, in sorry. Its bulk results in the increased thickness in areas that are the hindrance to the tongue. A horseshoe major connector has a tendency to flex or deform when a load is placed. Therefore, it is a poor choice for most maxillary applications. It may permit impingement of underlying tissue when subjected to occlusal load. Another maxillary major connector is palatal plate. The palatal plate major connector is a thin and wide metal plate that covers half or more of the hard palate, greatest amount of tissue coverage. The anterior border of palatal major connector follows valleys between ruga and does not extend anteriorly to indirect retainers on the first premolars. The posterior border is located at the junction of the hard and soft palates, but does not extend onto the soft palate. The palatal plate connector should be fabricated of a uniformly thin metal plate with accurate anatomic reproduction of the Rugo configuration. The large surface area of contact with the mucosa improves the potential for retention. The palatal plate, the palatal plate should cover the same area as a complete denture posteriorly. The posterior border can be fabricated of either metal or acrylic resin. If a posterior border is made of metal, the border must be precisely established because if overextended, it will quickly induce soreness, and the metal is difficult to alter satisfactorily. The acrylic resin border is preferred when maximum mediation and atmospheric seal is needed. Complete palatal plate major connector has an anatomic replica form for full palatal metal casting supported anteriorly by positive rest seats. It contacts all or almost all of the teeth remaining in the arch. If you look at the indications, situation in which only some anterior teeth remain when all posterior teeth to be replaced. Class 2 arch with a large posterior modification space and some missing anterior teeth. And class 1 arch with 1 to 4 premolars and some or all anterior teeth remaining. When the remaining teeth abutments are periodontally compromised, abutment support is poor, if abutment support is poor, and residual ridges have undergone resorption. Contraindication is the presence of severe tori, which cannot be surgically removed. Complete palatal coverage is advantageous when all posterior teeth are to be replaced and the remaining teeth are periodontally compromised. Complete palatal coverage provides vertical support. It permits force distribution to the teeth as well as the palatal tissues. And when minimal reach height is available, a palatal plate can provide additional stabilization for the prosthesis. It can be produced as a uniformly thin plate that reproduces the anatomic contours properly. As a result, it is comfortable and exerts little or no effect upon phonetics. Uniform thickness and the thermal conductivity of the metal are readily acceptable to the tongue and underlying tissues. It is an extremely rigid major connector. But because of the extensive tissue coverage, adverse soft tissue reaction in the form of inflammation or hyperplasia may occur. Problems with phonetics may be encountered. And the last maxillary major connector is anterior-posterior palatal straps. The anterior-posterior palatal strap is a structurally rigid major connector that may be used in most maxillary partial denture applications. This is particularly indicated when numerous teeth are to be replaced or when a palatine torus is present. The anterior-posterior palatal strap provides maximum rigidity and minimum bulk. Each strap should be at least 8 millimeters in width and relatively thin in cross-section. Borders of the major connector should be kept 6 millimeters from the free gingival margins or should extend onto the lingual surfaces of the remaining teeth. The strength of this major connector design lies in the fact that the anterior and posterior components are joined together by longitudinal connectors on either side, which form a square or rectangular frame. Each component braces the others against possible torque and flexure. When anterior teeth are not being replaced, the anterior strap should be an anterior Duyuyor musunuz arkadaşlar? When anterior teeth are not being replaced, the anterior strap should be in the farthest posterior position possible. Thus, appropriate placement promotes patient comfort and minimizes interferences with speech. The posterior strap also should be in a posterior position, but should not contact the tissue of the movable soft palate. İlerleyemiyorum. Niye böyle oluyor ya? Posterior palatal, şuraya gidelim. The open area in the palatal region should be 15 millimeters or more in an anterior-posterior dimension. Otherwise, another type of major connector should be chosen. For example, palatal strap or complete palate should be chosen. Posterior palatal strap should be flat and thin and a minimum of 8 millimeters wide and should exhibit smooth, gentle curves. It should be located as far posterior as possible to avoid interference with the tongue, but anterior to the line of flexure formed by the junction of the hard and soft palates. It should be located at right angles to midline rather than diagonally. Anterior component is a flat strap located as far posteriorly as possible to avoid ruga coverage and tongue interference. Anterior border of this strap should be located just posterior to a ruga crest or in the valley between two crests. Two palatal straps are connected by flat longitudinal elements on each side of lateral slope palate. If you look at the indications of anterior-posterior palatal straps, in class 1 and class 2 arches in which excellent abutment and residual ridge support exists, in longidental spans in class 2, modification 1 arches, and class 4 arches in which anterior teeth must be replaced with a removable partial denture and when an inoperable palatal theory is present. Inoperable maxillary torus that extends posteriorly to soft palate, a broad U-shaped major connector is used. We cannot use the anterior posterior palatal straps in these cases. Advantages. The anterior posterior palatal strap is a rigid connector that derives good support from the tissues of the hard palate despite its open design. The corrugated contour of the metal over the ruga adds strength to the connector and allows the metal to be made relatively thin. And the structural encirclement produced by the anterior and posterior straps contributes to rigidity of the connector and resistance to flexure. Even though the metal over the ruga area may be thinner than in some other major connectors, interference with phonetics may occur in some patients. In addition, the extensive length of borders may cause irritation to the tongue. And these are learning resources for this lecture. Arkadaşlar şimdi hemen ikinci derse başlayalım mı? Ne dersiniz? Yoksa bir 10 dakika ara verelim mi? Bence devam edelim isterseniz. Blok yapmış olalım. Olur mu?
Devam edelim hocam.
Tamam. O zaman bunu indirelim. Evet. Şimdi de mandibulara geçeceğiz. Now in this lecture I will give you information about mandibular major connectors. As you know from previous lectures, there are 6 types of mandibular major connectors. These are lingual bar, lingual plate, double lingual bar or lingual bar and Kennedy bar, labial bar, sublingual bar, cingulum and cingulum bar or continuous bar. Lingual bar and lingual plate major connectors are used in the overwhelming majority of removable partial denture applications. Double lingual bar and labial bar major connectors are used for special application in which lingual bars and lingual plates are contraindicated. Additional configurations, sublingual bar and cingulum bar, may be employed, but these major connectors are relatively rare. First, I want to talk about the lingual bar major connector. The lingual bar is perhaps the most frequently used mandibular major connector. The lingual bar traces along the lingual gingiva of the anterior teeth because of its
Hocam slaytlarınız geçmiyor.
Bu slaytı görmüyor musunuz, lingual bar slaytını?
Hayır hocam eski slaytta kaldı.
Evet.
Şunu görüyor musunuz şimdi?
Hayır.
Allah Allah.
Hocam galiba tek sayfa olarak paylaştığınız için bir önceki PowerPoint'in sadece sunumu kaldı diyeyim. Yenisini bir daha bizimle paylaşmanız gerekiyor.
Öyle mi? Tamam. O zaman kapatayım bunu. New share yapayım. Bir dakika. Baştan mı çıkıp girsem acaba diye düşündüm. Şu anda görüyor musunuz mandibular major connector slaytını?
Hayır hocam.
Göremiyorsunuz. Peki. Şimdi görüyor musunuz?
Evet hocam. Şu an
Tamam.
falan.
Tamam. Lingual bar majör konnektörlerden bahsediyorduk. İsterseniz bu slaytı görüyorsunuz değil mi şu anda? Devam edeyim böyle. The lingual bar is perhaps the most frequently used mandibular major connector. The lingual bar traces along the lingual gingiva of the anterior teeth. Because of its simplicity in design and construction, a lingual bar should be used unless one of the other connectors offers a definite advantage. The lingual bar should be used when sufficient space, a minimum 8 millimeters exists between the slightly elevated floor of the mouth lingual sulcus and the lingual gingiva. The patient is instructed to lift the tip of her tongue towards the middle of the hard palate while her mouth is open. This activates and raises the floor of the mouth. While the patient maintains this position, a periodontal probe can be positioned lingual to the mandibular anterior teeth in the oral cavity, and measurements are made from the floor of the mouth to the gingival margin. These measurements are transferred to the SteadyCast. Then the suitable type of major connector is selected. When viewed in cross-section, a lingual bar is half pear-shaped and at least 4 millimeters in height. The broadest portion of the bar is located at its inferior border nearest the floor of the mouth. Availability of space is the key factor in determining whether a lingual bar can be used. To accommodate a lingual bar, at least 8 millimeters of vertical space must be present between the gingival margins of the teeth and floor of the mouth. This permits the major connector to have a minimum height of 4 millimeters and allows 4 millimeters of space between the gingival margins and superior border of the bar. Failure to provide 4 millimeters of space may lead to irritation of adjacent soft tissues. Tissue relief under the lingual bar is necessary to protect the soft tissue of the floor of the mouth. Now let's look at the indication of the lingual bar. Lingual bar is the first choice major connector. It should be used when sufficient space equal or exceed 8 millimeters vertical space exists between the slightly elevated alveolar sulcus and the lingual gingival tissue. Contraindications of the lingual bar are inoperable lingual tori, high lingual frenal attachment, interferences during functional movements of the floor of the mouth when insufficient space, less than 8 millimeter vertical space exists between the slightly elevated alveolar lingual sulcus and the lingual gingival tissue, and if remaining natural anterior teeth is severely tilted lingually, we should not prefer lingual bar major connector. Now let me summarize the characteristics and location of this bar, major connector. It is half pear-shaped with bulkiest portion inferiorly located. Its superior border is tapered to soft tissue. Its superior border is located at least 4 millimeters inferior to gingival margins. Its inferior border is located at the ascertained height of the alveolar lingual sulcus when the patient's tongue is slightly elevated. Let's look at the advantages of the lingual bar. A lingual bar has simple design. It has minimal contact with the remaining teeth and soft tissues, so there is a decreased plaque accumulation and increased soft tissue stimulation. The greatest disadvantage is that if care is not taken in the design and construction of a lingual bar, the framework may not be rigid. This allows the concentration of destructive forces upon teeth and parts of the mandibular arch. Another mandibular major connector is a lingual plate. A lingual plate connector consists of a lingual bar plus a metal plate extending superiorly above the cingula, but not higher than the middle third of the teeth. The superior border must be scalloped so that it extends to the contacts interproximally. Lingual plate must always be supported by rests located no posterior than the mesial fossa of the first premolar. Failure to provide these rests may result in pronounced rotation of the framework and labial displacement of the remaining anterior teeth. Indications. No sufficient space, if no sufficient space for a lingual bar. When lingual frenum is high or space available.
İnternet çıkmadı, çekemedim. Burayı kodla çekiyordum. Sen kaçta gideceksin?
When lingual frenum is high or space
Alright.
available for lingual bar is insufficient, when insufficient space exists between the slightly elevated alveolar lingual sulcus and the lingual gingival tissue, a lingual plate is indicated in lieu of a lingual bar.
Yes.
In Kennedy class 1, where residual
Yine git. 1000 metre.
Arkadaşlar arkadan bir sesler geliyor. Mikrofonunuzu kapatabilir misiniz rica etsem? In Kennedy's class 1, where residual ridges have undergone excessive vertical resorption or when most posterior teeth are lost, we can choose to use lingual plate major connector. A flat residual ridges offer little resistance to the horizontal rotational tendencies of a denture. A correctly designed lingual plate will engage the remaining teeth to help resist horizontal rotations. For stabilizing periodontally weakened teeth, splinting with a lingual plate can be of some value when used with definite rests on sound adjacent teeth. When the future replacement of one or more anterior teeth is predicted, addition of retention loops to lingual plate will facilitate this. A lingual plate may also be necessary when the patient objects to a lingual bar in the presence of inoperable mandibular theory. We can prefer the lingual plate major connector. In the case of lingually inclined mandibular anterior teeth, and in the case of wide embrasures and diastema, lingual plate is contraindicated. However, a type of the lingual plate may be recommended in wide interproximal areas. Here, the upper border of the lingual plate is cut longitudinally to prevent its display through the wider interproximal spaces. If you look at the characteristics and location, the half pear-shaped portion is inferiorly located. Thin metal portion extending superiorly to contact cingula of anterior teeth and lingual surfaces of involved posterior teeth is at their height of contour. Thin metal portion is extended interproximally to the height of contact points. For example, closing interproximal spaces. Superior border is scalloped. Superior border is finished to continuous plane with the contact teeth. Inferior border is at the ascertained height of the alveolar lingual sulcus when the patient's tongue is slightly elevated. One of the greatest advantages of the lingual plate major connector is its excellent rigidity. It provides more support and stabilization when compared to other connectors. Easier denture tooth adhesion than bar if any tooth is extracted in the future. It can be used in stabilizing the periodontally weakened teeth. When posterior teeth have been lost and there is a need for additional indirect retention, the use of a lingual plate may be advantageous. It may contribute to indirect retention if it is properly rested at each end. Some patients often consider a well-fitting lingual plate more comfortable than a lingual bar. However, the lingual plate's extensive coverage may contribute to decalcification of enamel surfaces, irritation of the soft tissues, and periodontal problems in patients with poor oral hygiene. Another of the mandibular major connector is double lingual bar or lingual bar and Kennedy bar. The double lingual bar is composed of a conventional lingual bar and a second narrower bar located between the cingula inferiorly and the contact points superiorly. It's also called lingual bar and Kennedy bar. It distributes stresses to all of the teeth with which it comes in contact there by reducing the stresses to the underlying tissues. Two bars joined by minor connectors on each end. These are minor connectors. The gingival tissues and interproximal embrasures are not covered by the connector, which helps in free flow of saliva. Patient may feel discomfort because it alters the normal position of the tongue. If connector does not maintain intimate contact with tooth surface, there will be food entrapment. The secondary bar can act as an indirect retainer and performs the role in the horizontal stabilization of periodontally involved teeth. However, the performance of these functions is questionable. The form and placement of the inferior bar are exactly the same as for the lingual bar major connector. The superior bar must have rests in prepared rest seats, at least on the canines. Indications. When a lingual plate is indicated, but axial alignment of anterior teeth entails excessive blockout. When white diastema exists between mandibular anterior teeth, and a lingual plate would objectively display metal in a frontal view. If there is periodontal diseases resulting in large interproximal embrasures, we can prefer to use a double lingual bar. However, in case of any contraindication for a lingual bar, and if there are severely crowded anterior teeth, we must not use the double lingual bar. If I summarize the characteristics and location, the lower bar displays same characteristics as that of a lingual bar, half pear shaped in cross section. Thin, narrow to 2-3 millimeters in height and 1 millimeter thick upper bar is located on single of anterior teeth presenting scalloped appearance. It originates bilaterally from rests of adjacent principal abutments. Two bars are joined by minor connectors on each end. It is more rigid than lingual bar. It is advantages. It is more rigid than lingual bar. It covers less tooth and tissue surface than lingual plate. So a free flow of saliva is permitted and the marginal gingiva receives natural stimulation. However, patient may find a double lingual bar irritating to the tongue. The presence of multiple borders and the thickness of the upper bar are often annoying. If it does not maintain intimate contact with tooth surface, there will be food entrapment. Additionally, this major connector can create a food trap between the two bars. Another mandibular major connector is labial bar. The labial bar major connector is only selected when no other major connector will suffice. It is indicated when the remaining natural teeth are severely lingually inclined. Indications for it are extremely rare. Recontouring, orthodontic treatment, or restoration with crowns may correct the problems, severely lingually inclined teeth problems. But when such treatment is impossible or impractical, the labial bar is a possible solution. It is essentially similar to the lingual bar, and same rules apply for its use. The superior border of the labial bar should be at least 3 to 4 millimeters below the marginal gingiva. A labial bar runs across the mucosa on the facial surface of the mandibular arch. Like other mandibular major connectors, a labial bar displays a half-pear shape when viewed in cross-section. Let's look at the indications of the labial bar. When lingual inclination of remaining mandibular, premolar, and incisor teeth cannot be corrected, preventing placement of a conventional lingual bar connector, and severe lingual tori cannot be removed and prevent the use of a lingual bar or lingual plate major connector. And when severe lingual tissue undercuts make it impractical to use a lingual bar or lingual plate major connector. If there is inoperable facial tori or exostosis, or if there is any undercut in the facial alveolar ridge, or if there is a high facial muscle attachments, which would result in less than 3 millimeters of space between the superior edge of the labial bar and the marginal gingiva of the teeth, the labial bar is contraindicated. If we summarize the characteristics and location, the bulkiest lower part of the half-beer shaped labial bar is located on the labial and buccal aspects of the mandible. Superior border is tapered to soft tissue. Superior border is located at least 4 millimeters inferior to labial and buccal gingival margins and further is possible. Inferior border is located in the labial buccal vestibule at the junction of attached or immobile and unattached or mobile mucosa. Its advantage is that it can be used where lingual major connectors cannot be applied. Patient acceptance of a labial bar major connector generally is poor. The bulk of the labial bar major connector distorts the lower lip, and the presence of metal between the gingival tissues and the lip causes significant discomfort. The labial vestibule usually is not deep enough to permit a sufficiently rigid connector without encroaching on the pregingival margins. A labial major connector may be visible when the patient smiles, and it may distort lip contour, resulting in poor aesthetics. Another mandibular major connector is sublingual bar. It is modification of lingual bar used when the height of the floor of the mouth does not allow placement of superior border of the connector at least 4 millimeters below free gingival margin. The bar shape remains essentially the same as that of the lingual bar, but placement is inferior and posterior to the usual placement of a lingual bar, lying over and parallel to the anterior floor of the mouth. It is generally accepted that a sublingual bar can be used in lieu of a lingual plate if the lingual frenum does not interfere, or in the presence of an anterior lingual undercut that would require considerably block-out for a conventional lingual bar. When the height of the floor of the mouth in relation to the pregingival margin is less than 6 millimeters, we can use a sublingual bar, and when it is desired to keep the pregingival margins of the remaining anterior teeth exposed and depth of the floor of the mouth is inadequate to place the lingual bar, we can use a sublingual bar. In cases where remaining natural anterior teeth severely tilted towards the lingual, in the presence of the inoperable lingual tori and in the presence of a high attached lingual frenum, the sublingual bar is contraindicated. If you look at the characteristics, if I summarize characteristics and location, it's the same half-beer shape as lingual bar, except that the bulkiest portion is located to the lingual and the tapered portion is towards the labial. The superior border of the bar should be at least 3 millimeters from the pregingival margin, and inferior border is located at the height of the alveolar lingual sulcus when the patient's tongue is slightly elevated. As for the advantages of the sublingual bar, a sublingual bar does not contact anterior teeth or lingual alveolus. more aesthetic than other lingual major connectors because of its location, and more rigid than lingual bar because bulk of metal is horizontal rather than vertical. However, it requires further molded impression of floor of the mouth for accurate placement of major connector, and it is difficult to add artificial teeth to framework, and most patients prefer lingual plate to a sublingual bar. The last mandibular major connector is cingulum bar or continuous bar. When a lingual plate is the major connector of choice, but the axial alignment of the anterior teeth is such that excessive blockade of interproximal undercuts must be made, a cingulum bar may be considered. A cingulum bar is located on or slightly above the cingula of the anterior teeth. It may not provide adequate rigidity and it is rarely used. When improper axial alignment of the anterior teeth requiring excessive blockade of interproximal undercuts, the continuous bar may be used. However, if the anterior teeth severely tilted to the lingual, and when white diastema that exists between the mandibular anterior teeth and the cingulum bar would objectively display metal in a frontal view, the continuous bar is contraindicated. Thin, narrow metal strap is located on cingula of anterior teeth, and it is scalloped to follow interproximal embrasures with inferior and superior borders tapered to tooth surfaces. It originates bilaterally from incisal, cingulum, or occlusal rests of adjacent principal abutments. Although cingulum bar major connector may reduce the possibility of food entrapment, it may not provide adequate rigidity. Its disadvantage. We will move to next topic, minor connectors. A minor connector is the connecting link between the major connector of a removable partial denture and the other units of the prosthesis, such as clasps, indirect retainers, and occlusal rests. Primary function of the minor connectors is joining other units of the prosthesis and denture bases to the major connector, and it has dual function. It transfers functional stresses to the abutment teeth. This is a prosthesis to abutment function of the minor connector, and it transfers the effect of retainers, rests, stabilizing components throughout the prosthesis. This is an abutment to prosthesis function of the minor connector. If minor connectors are lacking or improperly designed, stresses remain localized in the area where they are generated. Properly designed minor connectors contribute to horizontal stabilization, reciprocation or bracing, and encirclement. There are three types of minor connectors based on their location. 1, proximal minor connectors. 2, embrasure minor connectors, and surface minor connectors. Proximal minor connectors contact an abutment tooth adjacent to an edentulous space. Proximal minor connectors are usually termed proximal plates, but are sometimes called guiding planes, struts, and finishing plates. Proximal plates extend from the proximal facial line angle of the tooth to the proximal lingual line angle of the tooth. They are thin mesiodistally and taper slightly towards the occlusal or incisal. They extend from the occlusal or incisal of the tooth to the major connector. The junction of rests, clasp arms, and major connector with proximal minor connectors is rounded right angles. Proximal plates extend cervically and contact the mucosa of the ridge crest for 2 to 3 millimeters. The part of the proximal minor connector which contacts the ridge crest is called the foot of the proximal plate. Other minor connector is embrasure minor connectors. Embrasure minor connectors are located between two teeth. They connect wrists and clasp arms to the major connector. It is triangular shaped in cross section. Embrasure minor connectors extend from the occlusal or cingulum surface of the tooth to the major connector. They join the major connector in a rounded right angle and they tapered slightly towards the occlusal or incisal. The last minor connector is surface minor connectors. Surface minor connectors are located on the lingual surface of incisors and canines. They connect lingual rests to the major connector. Their junction with the major connector is a rounded right angle and they taper towards the occlusal or incisals. Thanks for your attention. Arkadaşlarım ders burada bitti. Bana soracağınız bir şey varsa yanıtlayabilirim. İsterseniz şöyle bir genel tekrar da yapabiliriz. Ama hiç ses alamıyorum. O zaman dersi bitirelim arkadaşlar. Hepinize bundan sonraki dersinizde de iyi dersler diliyorum. Bir sonraki derste de galiba beraberiz. Ya da Emre Hoca sanırım bir arada bir ders anlatacak teorik. Ondan sonra yine biz devam edeceğiz. Öyle zannediyorum. Yani 2-3 dersimiz daha kaldı. O zaman ben bu ders çıktılarını en yakın sürede Classroom'da paylaşacağım. Tekrar görüşmek üzere. Hepinize iyi günler diliyorum. Sevgiler, hoşça kalın.
İyi günler hocam.
İyi günler hocam.
İyi günler.